Section A. Child Development and Feeding Skills in the First Year of Life. Section B. Nutritional Requirements of Different Pediatric Age Groups. Section C. Growth and Nutritional Assessment in Children. By the end of Section A, you will be able to understand the development of gastrointestinal and renal systems. Discuss infant development and feeding skills from birth through first year of life. By the end of Section B, you will be able to recognize the dietary requirements of different pediatric age groups. Understand indicators for assessing infant and young child feeding practices. Understand the amounts of nutrients required. By the end of Section C, you will be able to employ nutritional assessment methods in children. Understand World Health Organization growth charts and their use in the assessment of nutritional status. In the first section, we will discuss child development and feeding skills in the first year of life. Let us begin by discussing the development of the gastrointestinal and renal systems. The gastrointestinal tract is immature at birth. The activity of gastrointestinal enzymes is usually lower in neonates compared to adults. The activity of alpha amylase and other pancreatic enzymes is low up to the age of 4 months. Bile acids and lipase are also present in low concentrations in neonates. The rate of gastric emptying is very low at birth and prolongs to nearly 6 or 8 hours in the first day or so after delivery. Gastric emptying is irregular and erratic in the first year and approaches adult patterns by 6 to 8 months of age. Between 4 and 6 months of age, the ability of an infant to digest and absorb carbohydrates, proteins, and fats in newly introduced foods increases rapidly. Renal function is immature at birth and reaches complete maturity only by 2 years of age. Neonates have low glomerular filtration and tubular function. Given that the kidneys are immature at birth, the ability to handle free water and high solute loads is impaired in neonates. However, by 4 to 6 months of age, the infant's kidneys are capable of excreting waste products from foods with a high solute load. Hence, foods such as cow's milk, goat's milk, and high-protein foods with a high renal solute load should be avoided in neonates before 4 to 6 months. Now let us discuss the development of an infant's mouth patterns, hand, body, and feeding skills, and how these influence an infant's ability to feed. Newborn infants are capable of only sucking and swallowing liquids. This could be attributed to the limited development of feeding skills and mouth patterns in early infancy stages. A combination of mouth patterns, such as rooting, suck or swallow, tongue thrust, and gag reflex, enable a newborn infant to find the source of nourishment, suck and swallow the liquid. Till about 5 months of age, an infant's feeding skill is limited to only swallowing liquids and pushing most of the solid objects from the mouth. As infants mature, their mouth patterns, hand, body, and feeding skills develop further and set the stage for the introduction of complementary foods. Between 4 and 6 months, the tongue thrust and rooting reflex begin to disappear, and the gag reflex diminishes. Mouth patterns mature so that the infant is able to transfer food from the front to the back of the tongue to swallow food. The infant learns up and down munching movements and drawing in the upper and lower lips as the spoon is removed from the mouth. The infant is able to sit with support and develops good head control. Feeding skills also develop, and the infant is able to take in a spoonful of pureed or strained food and swallow it without choking. The table summarizes the sequence of development of infant feeding skills from birth through 6 months of age. Between 5 and 9 months, mouth patterns mature further to enable infants to control the position of food in the mouth and position food between the jaws for chewing. Infants are able to sit alone unsupported and follow food with their eyes. They even begin to use their hand motor skills to pick up objects. Their feeding skills enable them to begin eating mashed foods and drink from a cup. By 8 to 11 months of age, they learn to move food sideways in the mouth and chew in a rotary pattern. Their feeding skills enable them to eat ground, finely chopped, or soft food and drink from a cup with less spilling. Between 10 and 12 months, the rotary chewing skills are further established, and feeding skills enable the infant to eat chopped, soft, or cooked food. The infant also learns to feed himself or herself with a spoon with little help. In this section, we will discuss the nutritional requirements of different pediatric age groups. The World Health Organization and the United Nations Children's Fund recommend that breastfeeding be initiated early, within 1 hour of birth, and continued exclusively for the first 6 months of life. Breast milk is produced in 3 phases: colostrum, transitional milk, and mature milk. Colostrum, the first milk secreted after delivery, is usually termed liquid gold, since it is rich in nutrients required by an infant during the first days of life, including proteins, minerals, and fat-soluble vitamins. Transitional milk, the milk produced between 7 and 21 days postpartum, contains a high concentration of water-soluble vitamins, fat, and lactose. The calorie content of transitional milk is higher than that of colostrum. Mature milk, the milk produced 21 days after delivery, consists of 90% water, which is essential to maintain the infant's hydration status. The remaining 10% of breast milk is made up of proteins, fats, and carbohydrates that are essential to meet the infant's growth and energy needs. The important nutrients present in colostrum and mature milk are provided in the table. Although breast milk provides all the macronutrients required by an infant, it does not provide micronutrient such as iron and vitamin D in sufficient quantities. The World Health Organization and the United Nations Children's Fund recommend that nutritionally adequate and safe complementary or solid foods should be introduced at 6 months of age, along with continued breastfeeding up to 2 years of age or beyond. Beyond 6 months of age, the average energy and nutrient intake provided by 550 milliliters of breast milk are insufficient to meet the increasing demands of the growing infant, and hence, complementary feeds must be introduced to fill this energy and nutrient gap. Failure to introduce complementary foods or providing insufficient complementary foods at this age may lead to growth faltering of infants. In several countries, the incidence of growth faltering, infectious illnesses, and micronutrient deficiencies peak during the period of complementary feeding, that is, from 6 to 23 months. As shown in the graph on the left, breast milk provides all energy and nutrient needs up to 6 months of age. However, after 6 months of age, there is an energy gap of about 200 kilocalorie per day in infants aged 6 to 8 months, 300 kilocalorie per day in infants aged 9 to 11 months, and 550 kilocalorie per day in children aged 12 to 23 months of age. These gaps are not covered by breast milk. As the child grows and the intake of breast milk reduces, the amount of food needed to meet this energy gap increases. The graph on the right depicts the gaps in energy protein, vitamin A, and iron requirements, which are to be filled by complementary foods in breastfed children aged between 6 and 23 months. As can be seen, the largest gap is for iron, followed by energy, protein, and vitamin A. Hence, it is important to ensure an adequate supply of energy and nutrients through complementary foods in these children. Infants and children may require iron supplementation if they reside in regions with anemia prevalence in infants and younger children greater than or equal to 40%. The 2008 statement by the AAP recommends vitamin D supplementation in breastfed infants and in formula-fed infants if they are receiving less than 1 liter of formula. Further, fluoride supplements may be required for all children aged greater than 6 months if they live in communities with suboptimally fluoridated water, after carefully considering other fluoride exposures. In 1991, the World Health Organization and United Nations Children's Fund identified indicators to assess breastfeeding practices. Following developments in infant and young child feeding recommendations, the initially recommended indicators were revised in 2001. Given that child feeding practices are multidimensional and change rapidly within short age intervals in the first years of life, WHO updated the indicators in 2008 and identified 8 core and 7 optional indicators. These serve as simple, reliable, and valid indicators to track progress and guide investment to improve the health and nutrition of infants and children during the first 2 years of life. New inclusions in the core list include dietary diversity, feeding frequency, and minimum acceptable diet among breastfed and non-breastfed children aged 6 to 23 months. Let us discuss the new core indicators in detail in the next few slides. Minimum dietary diversity refers to the proportion of children aged 6 to 23 months who receive foods from 4 or more food groups. It serves as a proxy for adequate micronutrient density of foods and liquids other than breast milk. It can be calculated using the formula: children 6 to 23 months of age who received foods from more than or equal to 4 food groups during the previous day, divided by children 6 to 23 months of age. If a child aged 6 and 23 months of age consumes food from at least 4 out of the 7 recommended food groups on the previous day, it would indicate a high likelihood of consuming at least 1 fruit or vegetable and 1 animal source food, apart from the staple food. The 7 food groups used to calculate dietary diversity include grains, roots, and tubers, legumes and nuts, dairy products such as milk, yogurt, and cheese, flesh foods such as meat, poultry, fish, and liver or organ meat, egg, fruits and vegetables rich in vitamin A, and other fruits and vegetables. A point is added if any food from each of the 7 food groups is consumed. Children who consume items such as papilla, which is distributed in Peru, or bienestarina, which is distributed in Colombia, will receive a point for 2 food groups, that is, dairy products and grains, roots, and tubers, since papilla and bienestarina include both milk powder and grains. Eggs were included in the poultry food group in the Indonesia 2007 Demographic and Health Survey, Bangladesh 2007 Demographic and Health Survey, and the Demographic and Health Surveys conducted between 2002 and 2005. Thus, children who consumed poultry also received 1 point for eggs in these surveys. Minimum meal frequency refers to the proportion of breastfed and non-breastfed children aged 6 to 23 months who receive solid, semi-solid, or soft foods the minimum number of times or more, including milk feeds for non-breastfed children. The term minimum number of times refers to twice for breastfed infants aged 6 to 8 months and thrice for breastfed children aged 9 to 23 months. In non-breastfed children aged 6 to 23 months, the term minimum number of times refers to 4 times. Meal frequency in infants or young children should be based on the amount of energy needed by the child in a day, the amount of food a child can consume at each meal, and the energy density of that food. If the energy density of the food offered is between 0.8 and 1 kilocalorie per gram, then breastfed infants aged 6 to 8 months require 2 to 3 meals per day. Breastfed children aged 9 to 23 months require 3 to 4 meals per day, with additional 1 or 2 snacks as needed. For children who are not breastfed, 1 to 2 cups of milk and 1 to 2 extra meals per day should be given. Minimum meal frequency can be calculated from the following 2 fractions. Breastfed children 6 to 23 months of age who received solid, semi-solid, or soft foods the minimum number of times or more during the previous day, divided by breastfed children 6 to 23 months of age, and non-breastfed children 6 to 23 months of age who received solid, semi-solid, or soft foods or milk feeds the minimum number of times or more during the previous day, divided by non-breastfed children 6 to 23 months of age. Minimum acceptable diet refers to the proportion of children 6 to 23 months of age who receive a minimum acceptable diet apart from breast milk. It is calculated using the following 2 fractions. Breastfed children 6 to 23 months of age who had at least the minimum dietary diversity and the minimum meal frequency during the previous day, divided by the breastfed children 6 to 23 months of age, and non-breastfed children 6 to 23 months of age who received at least 2 milk feedings and had at least the minimum dietary diversity, not including milk feeds, and the minimum meal frequency during the previous day, divided by non-breastfed children 6 to 23 months of age. The minimum acceptable diet is a composite indicator of dietary diversity and feeding frequency by breastfeeding status. This indicator provides a useful way to track progress and simultaneously improve the quality and quantity of children's diets. After having discussed the population-based indicators, let us now discuss indicators that help to assess feeding practices in infants and young children at the individual level. Feeding practices in infants and young children can be assessed by using the feeding or intake history job aid presented on the slide. It includes assessing the child's breastfeeding status and obtaining information on other foods the child is receiving. If the child is breastfed, the number of times the child is breastfed during day and night has to be assessed. If expressed breast milk is used, information should be obtained on how the milk is stored and fed to the child. If the child is fed other foods, the number of meals and snacks per day, quantity of food given at each meal, and the consistency of the main meals has to be assessed. Additionally, it is important to assess whether the meal includes animal source foods, dairy products, dark green vegetables, or red or orange fruits or vegetables, pulses, and oil. Who helps the child to eat? What bowl the child gets food from? Whether the child is given any vitamin or mineral supplement, and how the child feeds during sickness. Apart from this, the United States Agency for International Development has developed an infant and child feeding practices monitoring tool and guide that can be used by community health workers to assess infant and child feeding practices in a healthy breastfed child who is not sick at the time of the counseling. The Feeding Practices Monitoring Tool helps to track practices or behaviors related to infant and young child feeding at an individual level and helps to achieve an optimal mix of practices for the child. The tool can be used to record practices related to 4 sets of indicators, namely breastfeeding, caloric density, nutrient density or dietary diversity, and food safety and feeding style. The amounts of nutrients recommended for each individual is referred to as Dietary Reference Intake, or DRI, in the United States of America, and as Recommended Nutrient Intake, or RNI, in most of the other countries in the world. The DRI is issued by the Institute of Medicine, which is now known as the National Academy of Sciences, Engineering, and Medicine, or NASEM. RNI is developed by the Food and Agricultural Organization of United Nations and World Health Organization. The DRI includes a set of reference values used to plan and assess the nutrient intake of healthy individuals. The different values vary based on the age and sex and include recommended dietary allowance, or RDA, adequate intake, or AI, and tolerable upper intake level, or UL. RDA refers to the average daily level of intake sufficient to meet the nutrient requirements of nearly all, that is, nearly 97 to 98% healthy people. Adequate intake is set at a level that is likely to ensure nutritional adequacy. Tolerable upper intake level refers to the maximum daily intake unlikely to cause adverse health effects. Let us discuss the definition of recommended nutrient intake in the next slide. The recommended nutrient intake, or RNI, as defined by Food and Agricultural Organization, or World Health Organization, refers to the daily intake set at the estimated average requirement plus 2 standard deviations, which meets the nutrient requirements of almost all apparently healthy individuals in an age and sex-specific population group. The estimated average requirement is defined as the average daily nutrient intake level that meets the needs of 50% of the healthy individuals in a particular age and gender group. For some micronutrients, the upper limits of nutrient intake have been set and are defined as the maximum intake from food, water, and supplements that is unlikely to pose risk of adverse health effects from excess in almost all apparently healthy individuals in an age and sex-specific population group. The tolerable upper intake level, or UL, is the level at which no evidence of toxicity is demonstrable. RNI is used by most countries in the world other than the U.S. However, some countries have developed their own national guidelines based on the RNI put forth by the FAO or WHO. In the subsequent slides, we will discuss the RNIs for vitamins, minerals, and proteins in infants and children. The World Health Organization recommendations for the intake of calcium, magnesium, selenium, and zinc in infants and children are depicted in this slide. In the adolescent group, the recommendations vary based on gender. The values for boys are presented in brackets. As can be seen, the recommended nutrient intakes of zinc are based on dietary bioavailability. This slide presents the National Academies of Sciences, Engineering, and Medicine's DRI for minerals calcium, magnesium, selenium, and zinc. Values that are presented in bold indicate the recommended dietary allowance, whereas values with an asterisk indicate adequate intake. The calcium requirements remain the same in children from the age of 9 up to 18 years. The table in this slide represents the recommended nutrient intakes for iron and iodine in infants and children, as specified by the Food and Agricultural Organization of the United Nations and World Health Organization. The recommended nutrient intake of iron differs based on the bioavailability of iron in the diet. Accordingly, RNIs are provided for bioavailability factors 5%, 10%, 12%, and 15% based on the composition of the typical local diet. The bioavailability of dietary iron varies greatly during 7 to 12 months of age. Neonatal iron stores are sufficient to meet the iron requirements for the first 6 months in full-term infants. Premature infants and low birth weight infants require additional iron. Iron requirements are greater in infants aged 7 to 12 months compared with children aged 1 to 3 years. The table in the slide presents the National Academies of Sciences, Engineering, and Medicine's DRI for minerals iron and iodine. The values that are given in bold indicate recommended dietary allowance, whereas the values presented with an asterisk indicate adequate intake. The recommended nutrient intake of vitamins, as specified by the FAO or WHO, is depicted in this slide. In the adolescent group, the recommendations vary based on gender. The values for boys are presented in brackets. The vitamin A values represent recommended safe intake and not the recommended nutrient intake. They are presented as microgram retinol equivalents per day. With regards to the RNI of vitamin E, data were not strong enough to formulate recommendations. Hence, the values presented in the table represent the best estimate of requirements. The RNI for vitamin K of 5 micrograms per day cannot be met by infants who are exclusively breastfed. All breastfed infants should be provided with vitamin K supplementation at birth, as per the nationally approved guidelines, in order to prevent bleeding due to vitamin K deficiency. The recommended intake of vitamin D is the same for infants and children up to the age of 9 years, at 5 micrograms per day. This slide presents the National Academies of Sciences, Engineering, and Medicine's DRI for vitamins. Values given in bold indicate recommended dietary allowance. Values given with an asterisk indicate adequate intake. Dietary protein requirements are at their highest between birth and weaning. Protein is required to support maintenance of body functions and high rates of tissue formation. The recommended nutrient intake for proteins in infants and children, both boys and girls, are depicted in the given table. The safe level of protein for a population is defined as the average protein requirement of the individuals in a population plus twice the standard deviation. Protein requirement is calculated in 2 steps. Firstly, the requirement per kilogram is obtained according to the age range. Secondly, this is multiplied either by the actual weight or by the median weight for age to obtain the total requirement. For example, the safe level of protein intake in infants aged 0.5 years is 1.31 gram per kilogram per day, while for those aged 1 year, it is 1.14 gram per kilogram per day. The recommended safe level of protein intake in gram per kilogram per day is the same for boys and girls up to the age of 10 years. This slide presents the National Academies of Sciences, Engineering, and Medicine's DRI for protein. The recommended nutrient intakes and dietary reference intakes provide information on the amount of nutrients to be consumed to ensure good health and prevent diseases. However, consumers may find it difficult to ensure adequate nutrient intake based on these recommendations. They can also get confused by the composition of nutrients, such as carbohydrates, fat, protein, etc., displayed on food labels. To simplify this information and provide general indications to a population on what food to consume, rather than nutrients, organizations such as the Food and Agricultural Organization and the World Health Organization have developed food-based dietary guidelines. Food-based dietary guidelines provide information to the general public on foods, food groups, and dietary patterns to be followed to ensure the intake of required nutrients, promote overall health, and prevent diseases. These guidelines are specific to each nation and are based on the local cultural, social, and economic conditions. There can be significant variations in the advice on dietary fats and carbohydrates based on the nutritional problems in each nation. Globally, however, these guidelines stress the importance of consuming fruits and vegetables in increased quantities, discourage excessive consumption of salt, sugar, saturated fats, and alcohol, and increasing physical activity. Let us now discuss the food-based dietary guideline, MyPlate, adopted in the United States. The MyPlate concept, which replaced the MyPyramid concept, was introduced based on the 2010 Dietary Guidelines for Americans. It is designed to assist consumers in making better food choices and aims to remind Americans to eat healthily. It is not intended to change consumer behavior per se. MyPlate illustrates the 5 food groups using a familiar mealtime visual, a place setting. MyPlate recommends consumption of foods from all food groups, namely fruits, vegetables, low-fat dairy products, whole grains, and lean protein foods. Additionally, it is recommended to ensure that half the plate contains fruits and vegetables. At least half the grains on the plate are whole grains. Protein food choices are varied. Sodium intake is limited. And skimmed or 1% milk is used. Additionally, the United States Department of Agriculture recommends greater than 60 minutes of physical activity in children and adolescents. In February 2015, the 2015 Dietary Guidelines Advisory Committee submitted the scientific report of the 2015 Dietary Guidelines Advisory Committee to the Secretaries of the U.S. Departments of Health and Human Services and Agriculture. Based on this report, the 2015 to 2020 Dietary Guidelines for Americans were released. These guidelines emphasize on following a healthy eating pattern across the lifespan, including a variety of nutrient-dense foods across and within all food groups in recommended amounts, limiting calories from added sugars and saturated fats, and reducing sodium intake, shifting to healthier food and beverage choices, and supporting healthy eating patterns for all age groups. Let us now look at using MyPlate in preschoolers. It is suggested to include 1 cup of fruit for a 2-year-old child and 1 to 1.5 cups of fruit for children aged 3 to 5 years. Half a cup of fruit refers to half cup mashed, sliced, or chopped fruit, half cup of 100% fruit juice, half medium-sized banana, or 4 to 5 large strawberries. The quantity of vegetables to be offered for children aged 2 years is 1 cup. For 3-year-olds, it is 1.5 cup, and for 4 to 5-year-old children, it is 1.5 to 2 cups. Half a cup of vegetables refers to half cup mashed, sliced, or chopped vegetables. 1 cup raw leafy greens. Half cup vegetable juice, or 1 small ear of corn. The quantity of grains to be offered to children aged 2 years is 3 ounces, or 85 grams, and for those aged 3 to 5 years, it is 4 to 5 ounces, or 113 to 141 grams. 1 ounce of grains refers to 1 slice bread, 1 cup ready-to-eat cereal flakes, half cup cooked rice or pasta, or 1 tortilla sized 6 inches across. The quantity of proteins to be offered to children aged 2 years is 2 ounces or 57 grams. For those aged 3 years, it is 3 to 4 ounces or 85 to 113 grams. And for 4 to 5-year-olds, it is 3 to 5 ounces or 85 to 141 grams. 1 ounce of protein foods refers to 1 ounce of cooked meat, poultry, or seafood, 1 egg, 1 tablespoon peanut butter, or 1/4 cup cooked beans or peas. About 2 cups, or 473 milliliters of dairy products should be provided to children aged 2 to 3 years, and about 2.5 cups, or 591 milliliters, should be provided to 4 to 5-year-old children. Half a cup of dairy products refers to half cup milk, 4 ounces yogurt, 3/4 ounce cheese, or 1 string cheese. 1 ounce is equal to 28.3495 grams, and 1 cup is equal to 236.588 milliliters. MyPlate food plans for preschoolers are based on average needs of children. A child may need more or less food than the average, and parents should not be concerned if their child does not eat the exact amount suggested. Food needs are increased during growth spurts, and children's appetite may differ from day to day. Let us now discuss different methods to assess growth and nutritional status in children. Before we proceed to growth assessment in children, let us discuss a few terminologies put forth by the World Health Organization. Malnutrition refers to all forms of poor nutrition caused by a complex array of factors, including dietary inadequacy, deficiencies, excesses or imbalances in energy, protein, and micronutrients, and includes both undernutrition and overnutrition. It is defined as the cellular imbalance between the supply of nutrients and energy and the body's demand for them to ensure growth, maintenance, and specific functions. Undernutrition refers to being underweight for age, too short for age, or stunted, too thin relative to height, or wasted, and functionally deficient in vitamins and minerals, micronutrient malnutrition. Overnutrition is defined as abnormal or excessive fat accumulation that may impair health. Overnutrition leads to becoming overweight and obese. Micronutrient malnutrition, or hidden hunger, refers to diseases caused by a dietary deficiency of vitamins or minerals. Wasting, or low weight for height, is defined as weight for height less than 2 standard deviations below the WHO Child Growth Standards mean weight for height. It is often associated with acute starvation or severe disease. Stunting, or low height for age, is defined as height less than 2 standard deviations below the median height for age of the standard reference population. The American Society for Parenteral and Enteral Nutrition, ASPEN, has proposed a novel and comprehensive definition of pediatric malnutrition. The practical scheme for defining pediatric malnutrition is presented on the slide. Pediatric malnutrition or undernutrition is defined as an imbalance between nutrient requirements and intake that results in cumulative deficits of energy, protein, or micronutrients that may negatively affect growth, development, and other relevant outcomes. The new scheme to define malnutrition incorporates chronicity, etiology, mechanisms of nutrient imbalance, association with inflammation, severity of malnutrition, and its impact on outcomes. Using 3 months as a cutoff to classify duration of malnutrition, malnutrition is classified as acute, that is, less than 3 months, and chronic, that is, 3 months and longer. For each child, malnutrition should be diagnosed based on anthropometric parameters and their cutoffs. Accordingly, a child is considered to be mildly malnourished or at risk of malnutrition if the Z-score is less than or equal to 1. A Z-score between -2 and -3 is considered moderate malnutrition, while a Z-score less than or equal to 3 is considered severe malnutrition. Based on etiology, malnutrition can be either illness-related, that is, secondary to one or more diseases or injury, or non-illness related, that is, caused by environmental or behavioral factors. Inflammation is usually severe or moderate in acute illnesses and mild in chronic illnesses. Inflammation is absent in chronic malnutrition. Specific pathogenic mechanisms implicated in malnutrition may include decreased nutrient intake, as in starvation, increased nutrient requirement, increased nutrient losses, or altered nutrient utilization. Apart from the anthropometric parameters affected, other outcomes that may be affected include achievement of age-appropriate developmental milestones, lean body mass measurements, muscle strength, immune function or dysfunction, frequency or severity of acquired infections, wound healing, length of hospitalization, and disease-specific resource utilization. Assessment of nutritional status is an essential and integral part of clinical care in pediatrics. It is particularly important to assess nutritional status in children due to the rapid growth and development that occurs during this age, which is dependent on the genetic makeup and nutritional status. Nutritional assessment can help in identifying nutrient deficiencies and excesses early on and in designing appropriate intervention. Different methods used to assess nutritional status include the following: Anthropometric Assessment, Biochemical Assessment, Clinical Assessment, Dietary Assessment. No single measure is complete in itself, and each has its own advantages and disadvantages. Therefore, a combination of different measures is required. Let us discuss each of these methods in detail in the subsequent slides. The different anthropometric parameters that are used include height, weight, head circumference, mid-upper arm circumference, and skin fold thickness. The measurement of height, weight, and head circumference indicates growth status. The measurement of mid-upper arm circumference and skin fold thickness indicates body composition. The strengths and limitations of these parameters are presented in the table. Measurement of height indicates long-term nutritional status. Serial measures are more beneficial than a single measure. However, height measurements are influenced by non-nutritional factors, such as genetics and hormones, and require accurate stadiometer to record the findings. Weight is a basic measure of nutritional status. Trends in weight measured over time are a better indicator of nutritional status than a single measure. However, accurate scales and the age of the child are essential to measure weight. Measurement of head circumference is a simple technique. However, the measurement is influenced by non-nutritional factors and is not beneficial to assess nutritional status. Points to remember. Measurements of length are 0.5 to 1.5 centimeter greater than measurements of height. In children older than 2 years or taller than 85 centimeters, subtract 1 centimeter from the length measurement before comparing with reference values. Height and length should be recorded to the nearest 0.1 centimeter. Weight should be recorded to the nearest 0.1 kilogram. The head circumference should be recorded to the nearest 0.1 centimeter. Measurement of mid-upper arm circumference indicates the amount of subcutaneous fat and muscle. Changes in these measurements are positively associated with changes in weight. Measurements are recorded to the nearest 0.1 centimeter. This method does not require the measurement of height or weight of a child. It can be used in emergency situations and in rapid surveys. Measurement of skin fold thickness indicates the amount of total body fat and subcutaneous fat. Skin fold thickness is commonly measured around the biceps, triceps, subscapular, mid-axillary, and suprailiac areas. Measurements from a minimum of 2 sites are recommended, preferably the limb, for example triceps, and the body, for example subscapular area, as these serve as measures of body fat. While using a Lang calipers, the skin fold thickness should be recorded to the nearest 0.5 millimeter, and with the Holtain calipers, the measurement should be to the nearest 0.2 millimeters. Measurement of skin fold thickness may be of limited value in evaluating undernutrition in children due to large inter-observer variability and absence of reference data. Children who present to a health facility should be assessed based on the integrated management of childhood illness strategy. Initially, the child should be evaluated for general signs of danger, such as the inability to breastfeed or drink, persistent vomiting, lethargy, convulsions, or loss of consciousness. If any danger signs are identified, the child should be urgently assessed, managed specifically, and referred to the nearest hospital. Following the initial evaluation, the nutritional status of the child should be assessed by examining the skin, eyes, hair, nails, mouth, subcutaneous tissue, muscle bulk, bones, abdomen, thyroid, and the central nervous and cardiac systems. The presence of pallor, especially palms, may indicate iron or folic acid deficiency. Ecchymosis indicates vitamin K deficiency. Hypo or hyperpigmentation, desquamation, and ulceration indicate zinc or protein deficiency. Perifollicular hyperkeratosis indicates vitamin A deficiency, and hyperpigmentation of exposed areas indicates niacin deficiency. The presence of night blindness, xerotic conjunctiva, xerotic cornea, Bitots spots, keratomalacia, or corneal scars indicate vitamin A deficiency. The presence of conjunctival pallor indicates iron or folic acid deficiency. The presence of hair that is depigmented, easily pluckable, or sparse indicates kwashiorkor. Koilonychia indicates iron deficiency. In the mouth, the presence of chylosis, glossitis, loss of papillae, or magenta tongue indicates riboflavin deficiency, whereas glossitis or scarlet tongue indicates niacin deficiency. Bleeding gums indicate vitamin C deficiency. This table presents the clinical features of probable nutrient deficiencies that can be assessed on examination of the subcutaneous tissue, muscle bulk, bones, abdomen, central nervous system, cardiac system, and thyroid. Reduced subcutaneous tissue and fat indicate energy deficiency, whereas edema indicates sodium and potassium disturbances, or hypoalbuminemia. Muscle wasting and weakness indicate undernutrition. On examination of the bones, the presence of craniotabes, costochondral junctions, widening of metaphyses of the wrists and ankle, frontal bossing, wide anterior fontanelle, rickety rosary, delayed dentition, or bow legs indicates a deficiency of vitamin D. Bony tenderness and pseudoparalysis indicate vitamin C deficiency. Inadequate bone mass or osteoporosis indicate calcium deficiency. On examination of the abdomen, the presence of hepatomegaly may indicate kwashiorkor. If the child appears apathetic, it may be an indication of kwashiorkor or iron deficiency. Peripheral neuropathy may indicate thiamine or pyridoxine deficiency. Cardiac failure or enlargement may be an indication of thiamine deficiency. The presence of goiter indicates iodine deficiency. This slide presents strengths and limitations of different dietary assessment methods. The 24-hour recall is a relatively easy and inexpensive method. It provides detailed information on foods consumed. It can be used to quantify nutrient intake. However, a single recall may not represent usual intake. Under- or over-reporting may be possible. Omissions can lead to low energy intake estimates. The Food Frequency Questionnaire is also inexpensive. It can be used to assess the association between diet and disease. However, it is not appropriate to assess the diet of an individual patient, and portion sizes are not determined in this method. This method may not represent seasonal foods and cannot be used to determine nutrient intake. Food records are not memory dependent and provide information on eating habits. They are more representative of actual intake, and the entries can be reasonably valid for up to 5 days. However, it is time-consuming, and the analysis is expensive. Additionally, diet may vary with the need to record. The diet history can detect seasonal changes. However, it is time-consuming, can overestimate intake, and provides qualitative rather than quantitative data. Let us now discuss how to assess dietary intake. In children less than 2 years of age, it is important to record whether the child is exclusively breastfed or formula-fed, and whether the child is being fed complementary foods. The type, amount, frequency of feeding, method of preparation, and brand of complementary or formula food should also be recorded. In children aged 2 years and above, the quantity, type, frequency of foods consumed daily, feeding environment, habits, and patterns should be recorded. Additionally, in all children, it is important to record the appetite, dietary restrictions, food aversions, and use of drugs, including mineral and vitamin supplements. Dietary intake can be recorded using various tools, such as 24-hour dietary recall, food record diary, dietary history, or a food frequency questionnaire. The 24-hour dietary recall records a detailed description of all foods and drinks consumed on the previous day. The methods of cooking and brand names are also recorded, if available. A single 24-hour recall entry may not be appropriate to assess the usual food or nutrient intake due to day-to-day variations. In the Food Frequency Questionnaire, the daily, weekly, monthly, or yearly frequency of consumption of major foods is recorded. In the food record diary method, all the food and beverages consumed are recorded over a specified period using household measures or weights. The foods eaten and their method of preparation and cooking are also recorded in detail. The dietary history records the dietary intake over a month or a year. However, it is important to note that a dietitian or trained nutritionist is required to obtain information for dietary assessment. Proteins synthesized by the liver decrease when the supply of amino acid precursors is lower or when the liver mass is reduced. Therefore, clinicians and investigators have used them to evaluate nutritional status. However, plasma proteins levels can increase or decrease during metabolic stress and fluid shifts. The table in the slide presents the classification of plasma proteins based on whether their concentration increases or decreases during an acute infection or catabolism. The concentrations of positive acute phase proteins increase during infections and other catabolic illnesses due to preferential secretion by the liver. However, the concentrations of negative acute phase proteins are reduced during metabolic stress. The magnitude of the effect of a positive acute phase reaction is attenuated during protein energy malnutrition. Biochemical assessment is not routinely recommended to evaluate the nutritional status due to the lack of a single test or a group of tests to reliably determine nutritional status. Additionally, technology and trained staff are required to perform a biochemical assessment. At an individual level, this method can be used to assess micro and macronutrient status, identify specific metabolic abnormalities usually associated with systemic disorders, monitor specific therapeutic interventions, and prognostically determine morbidity and mortality. At the population level, this method can be used to screen for micronutrient deficiencies, such as iron and vitamin A, and to monitor specific population-based interventions. The usefulness of some laboratory tests that can be used to assess the nutritional status is presented in the table. Protein deficiency can be evaluated by testing transferrin and transthyretin levels and by assessing nitrogen balance. Transferrin and transthyretin levels may be reduced in infections. Plasma calcium and phosphate are good indicators of vitamin D levels, and reduced levels may be the first sign of deficiency. Measurement of the active form 1,25 OH2D is not useful in clinical practice and is more important for the endocrine evaluation of bone disease. 25-OHD may not be a good marker of vitamin D stores in individuals with inflammation, infection, or obesity. Serum folate and red cell folate levels are useful tests to determine folate deficiency. Thyroid function tests can provide information on iodine deficiency. During an acute phase response, serum iron and transferrin levels reduce, while ferritin levels increase, since ferritin is released from the liver. Therefore, in the presence of acute inflammation, conventional iron studies are very difficult to interpret. In such situations, mean blood cell volume and hemoglobin concentrations may be more helpful as indicators of iron status. As an alternative, soluble transferrin receptor, a newer marker of cellular iron index, may be used either independently or as part of the soluble transferrin receptor or log ferritin index. Establishing a diagnosis of zinc deficiency may be difficult under conditions of metabolic stress, since zinc levels may reduce during states of inflammation. Therefore, serum and plasma zinc levels are not considered accurate indicators of zinc deficiency. vitamin E deficiency can be monitored by testing serum vitamin E levels or the ratio of vitamin E to total lipids. Thus, it is evident that most of these nutritional biomarkers are influenced by acute illness and metabolic stress. Let us now discuss the suggested schedule for growth assessment in healthy and hospitalized children. In hospitalized infants or children, the schedule of measurement is based on the age, illness, and degree of nutritional intervention. The hospitalized preterm infant or child needs frequent monitoring of weight, height, and head circumference. In the outpatient child who is well, these parameters can be monitored on a monthly basis or every 2 to 3 months after 2 months of age. Between 2 and 6 years, annual monitoring is suggested, and between 6 and 10 years, monitoring is suggested every 2 years. The table in the slide provides the suggested schedule for growth assessment adapted from the American Academy of Pediatrics. There is no WHO recommended schedule of visits, especially to assess growth, although some countries may recommend a schedule, such as 6 visits in the first 2 years of life. Growth is assessed through growth indicators based on a child's age and physical measurements. The different indicators that are useful for assessing growth in children are length or height for age, weight for age, weight for length or height, body mass index for age. These indicators are measured using age and sex-specific charts. Before we proceed to the different growth charts, let us first discuss the components of growth charts. A growth chart contains an x-axis, which is the horizontal line at the bottom of the graph. In some graphs, it depicts the age, while in others, it depicts length or height. A y-axis, which is the vertical line at the extreme left of the graph, can be a measure of length or height, weight, or body mass index. Plotted point, which is a point on a graph where a line extended from a measurement on the x-axis meets the line extended from a measurement on the y-axis. In the growth chart shown in the slide, the x-axis depicts age in weeks or months, and the y-axis depicts weight in kilograms. The curved lines help to interpret the plotted points that represent a child's growth status. The line labeled 0 is considered the median or average value. The other curved lines, called z-score lines, represent the distance from the average. These lines are numbered positively or negatively. Growth issues are indicated by a plotted point or trend that is far from the median in either direction, such as 3 or -3. The precise age of the child is required to assess growth indicators and use growth charts. The age of a child can be determined using a computerized system or the WHO Child Age Calculator. If the age of a child is not known, a local events calendar should be used to determine the child's likely age. In preterm infants, corrected age should be used to determine growth and development. Corrected age is calculated by subtracting the number of weeks born before 40 weeks of gestation from the chronological age. Thus, the corrected age of a 24-month-old infant born at 28 weeks of gestation is 21 months, according to the equation given in the slide. 24 months minus 40 weeks minus 28 weeks times 1 month divided by 4 weeks. Let us now discuss plotting a length or height for age chart in children aged 2 to 5 years. This type of chart reflects the growth attained in length or height at the child's age at a given visit. This chart helps to identify children who are stunting or stunted or are excessively tall for their age. Let us now discuss the steps involved in plotting a length or height for age chart. First, plot the age based on completed weeks, months, or years and months on a vertical line and not between the vertical lines. Suppose a child is 5.5 months old. The point will be plotted on the line for 5 months and not between the lines for 5 and 6 months. Next, plot the length or height on or between the horizontal lines as accurately as possible. Suppose the measurement is 60.5 centimeters. The point should be plotted in the middle of the space between the horizontal lines. Connect adjacent points plotted for 2 or more visits with a straight line to observe the trend better. Gauge whether the plotted points seem sensible. If required, measure the child again. Remember that the child's length should not be shorter than the length measured at the previous visit. The graph in the slide depicts Maria's height for age at 3 visits. Horizontal lines indicate increments of 1 centimeter. At the first visit, when Maria was 2 years and 4 months, her height was 92 centimeters. During her second visit, at 3 years and 3 months, her height was 98 centimeters. And during her third visit at 4 years and 2 months, her height was 103 centimeters. A child with a Z-score above 3 is considered to be very tall. A Z-score below -2 indicates stunting or being stunted, depending on the age, and a score below -3 indicates severe stunting or being severely stunted, depending on the age. The findings have to be interpreted based on the age of the child. For children aged between 2 and 3 years, low height for age probably reflects a continuing process of failing to grow or stunting. However, for children aged more than 3 years, a low height for age score reflects a state of having failed to grow or being stunted. In this slide, we will look at how to plot the weight for age chart. This type of chart is a reflection of the child's weight relative to its age on a given day. It is widely used to evaluate if a child is underweight or severely underweight. A child may be underweight due to short length or height, that is, stunting, thinness, or both. However, this chart cannot be used to classify a child as overweight or obese. It is also not useful in situations where the child's age cannot be accurately determined. Let us now discuss the steps involved in plotting the weight for age chart. First, plot the completed age of the child in weeks, months, or years on a vertical line and not between vertical lines, as discussed in the previous slide. Next, plot the weight on a horizontal line or in the space between lines to show weight measurement to 0.1 kilograms, for example, 7.7 kilograms. Connect the adjacent points to make a straight line when points are plotted for 2 or more visits. This helps in observing at 3 different visits for a boy named Amal. The horizontal lines indicate increments of 0.1 kilograms or 100 grams. Amal weighed 8 kilograms at age 9 months, less than 9 kilograms at 1 year and 1 month, and 9.1 kilograms at his third visit at 1 year and 6 months. A child with a Z-score of -2 is considered to be underweight. A child with a Z-score of below -3 is severely underweight. Points to remember. In children with edema of both feet, the weight may appear to be increased due to fluid retention, and thus the presence of very low weight may go unnoticed. In such instances, plot the child's weight for age and weight for length or height, and mention clearly near the plotted point that the child has edema. Such children should be considered severely undernourished and referred for specialized care. The weight for length or height chart is a reflection of body weight, proportional to growth, attained in length or height. This chart is helpful in identifying children with low weight for height who may be wasted or severely wasted, as well as those with high weight for length or height who may be at risk of becoming overweight or obese. Let us now discuss the steps involved in plotting the weight for length or height chart. First, plot length or height on the vertical line and round it off to the nearest whole centimeter. For example, round off 0.5 to 0.9 and 0.1 to 0.4, and follow the line up from the x-axis to wherever it meets the weight measurement. Next, plot the weight as precisely as possible. Connect the adjacent points to make a straight line when points are plotted for 2 or more visits. This could be helpful in observing trends. The chart in the slide shows Tom's weight for length. The vertical lines indicate increments in 0.5 kilograms or 500 grams. The horizontal lines indicate increments in 1 centimeter. At 3.5 months, Tom weighed 10 kilograms and his length was 63 centimeters. The plotted point on the weight for length chart is above the z-score line 3. A child whose z-score is above 3 is obese, above 2 is overweight, and above 1 is at a possible risk of being overweight. A z-score below -2 indicates wasting, and a z-score below -3 indicates severe wasting. In this case, Tom's growth chart indicates that he is obese. The BMI for age chart is useful to screen for overweight and obesity in children. Let us now discuss the steps to plot a BMI for age chart. First, plot the age in completed weeks, months, or years and months on the vertical line and not between vertical lines. Next, plot the BMI on a horizontal line or in the space between lines. If BMI is determined using a calculator, then the value may be recorded and plotted to 1 decimal place. Connect adjacent points to make a straight line when points are plotted for 2 or more visits. This could be helpful in observing the growth trends. The chart in the slide depicts the BMI for age of Mark at 3 visits. During his first visit, Mark was 3 years old with a BMI of 17.2 kilograms per meter square. During his second visit, at 3 years, 6 months, Mark's BMI was 17.8 kilograms per meter square. At his third visit at 4 years, Mark's BMI was 18 kilograms per meter square. A child with a BMI for age z-score above 3 is obese, above 2 is overweight, and above 1 is at possible risk of becoming overweight. A z-score below -2 indicates wasting, and a score below -3 indicates severe wasting. In this case, Mark's BMI for age chart indicates a trend towards becoming overweight. If his growth line crosses the z-score line 2, Mark will be considered overweight. At this point, it is important to understand the relevance of BMI in children below 2 years. The World Health Organization recommends the use of BMI for age chart in children and adolescents from birth through 19 years. However, the Centers for Disease Control and Prevention does not recommend the use of BMI for age in children aged less than 2 years. After having plotted the different parameters on the growth charts, the presence of growth problems, if any, can be identified by comparing the plotted points on the growth charts with the z-score lines. The z-scores may also be termed standard deviation scores. The table in the slide summarizes how to identify growth problems based on the plotted points on growth charts in children up to the age of 5 years. Measurements provided in the shaded boxes indicate normal ranges. If a growth indicator is plotted exactly on the z-score line, it is considered to be in the less severe category. For example, if the weight for age for a child is plotted on the -3 line, the child is considered to be underweight and not severely underweight. A child with a z-score above 3 on the length or height for age chart is considered very tall. Tallness is rarely a problem unless it is so excessive that it may indicate an endocrine disorder, such as a growth hormone-producing tumor. A child with z-scores in this range should be referred to assessment if an endocrine disorder is suspected, that is, when parents of normal height have a child who is excessively tall for his or her age. If the z-score is below -2, it indicates stunting, while a z-score below -3 indicates severe stunting. A child with stunting or severe stunting may become overweight. A z-score of above 1, 2, or 3 on the weight for age chart indicates that the child may have a growth problem. However, this is better assessed using weight for length or height, or BMI for age chart. A plotted line above a z-score of 1 in the BMI for age chart indicates a possible risk of becoming overweight. A z-score of above 2 indicates being overweight, and a score above 3 indicates obesity. The table in the slide summarizes how to identify growth problems from plotted points for children aged 5 to 19 years. In the BMI for age chart, a score greater than 1 SD, equivalent to BMI of 25 kilograms per meter square at 19 years, indicates being overweight. A score greater than 2 SD, equivalent to BMI 30 kilograms per meter square at 19 years, indicates being obese, and a score greater than 3 SD indicates being severely obese. In children up to 10 years of age, a score less than -2 SD and less than -3 SD on the weight for age chart indicates underweight, and a score less than -3 SD indicates severe underweight. In the height for age chart, a score less than -2 SD to less than -3 SD indicates being stunted, and a score less than -3 SD indicates being severely stunted. According to the World Health Organization Global Database on Child Growth and Malnutrition, a z-score cutoff point of less than -2 SD is used to classify low weight for age, low height for age, and low weight for height as moderate and severe undernutrition in children aged less than 5 years. A z-score cutoff point of less than -3 SD is used to define severe undernutrition. While some countries use the WHO z-score cutoff points, others use the Centers for Disease Control and Prevention z-scores. A composite assessment of a child's growth and nutritional status can be done by considering all the growth charts together, especially if only one chart indicates a growth problem, and by considering trends observed over a period of time. For example, if the weight for age chart indicates that a child is underweight, then the child's length for age and weight for length chart must also be considered. The length or height for age and weight for length or height charts should be given more attention in this scenario. If the z-score is below -2 on the length or height for age chart, indicating stunting, it can be inferred that the child has remained undernourished for a long time, and/or that the child has experienced repeated infections. However, stunting can also occur due to non-nutritional causes, such as genetic conditions, endocrine disorders, inflammatory bowel disease, etc. These causes are not discussed in detail in this presentation. The weight for height chart of a stunted child may be normal, but the weight for age chart may have low values due to shortness. If the z-score is below -2 on the weight for length or height chart, it indicates wasting. Wasting is usually the result of a recent severe event, such as drastically reduced food intake and/or severe illness that led to severe weight loss. Trends in a child's growth can be identified by looking at points plotted during a series of visits. These trends indicate whether a child's growth is consistent and well, or there is a growth problem, or that the child is at risk of developing a problem and needs immediate reassessment. Trends that are generally parallel to the median and z-score lines indicate normal growth. The trends in most children will follow a track below or above the median and on or between the z-score lines. The presence of any of these findings may indicate a problem or suggest a risk. A flat line, since it indicates that the child is not growing. A growth line that crosses a z-score line. Sharp incline or decline in the growth line. However, a decision on whether the above situations indicate a risk or problem is made based on the time of onset and direction of the change in the growth trend. For example, in a child who is ill and lost weight, a rapid gain represented by a short incline on a growth chart may indicate catch-up growth, which is good. Similarly, in a child who is overweight, if the growth trend is slightly declining, or if a flat weight growth trend is observed towards the median, it may represent catch-down growth, which is desirable. Hence, it is important to consider the overall situation of the child while interpreting trends on growth charts. We have come to the end of this module. Let us recap key messages of this module. Nutrition during the early years of life should be based on the development and maturity of the infant's gastrointestinal and renal systems, hand, body, and feeding skills. Breast milk is the best food source for infants until 6 months of age. Beyond 6 months, complementary feeds must be introduced. FBDG provide general indications on what foods to consume rather than nutrients. They are specific to each nation. Nutritional status in children can be assessed using anthropometric, biochemical, clinical, or dietary methods. Different indicators used to assess growth include length or height for age, weight for age, weight for length or height, and body mass index for age charts. The precise age of the child is required to assess growth indicators and use growth charts. In preterm infants, corrected age should be used to determine growth and development. A z-score cutoff point of less than -2 SD is used to classify low weight for age, low height for age, and low weight for height as moderate and severe undernutrition in children aged less than 5 years. A z-score cutoff point of less than -3 SD is used to define severe undernutrition in children aged less than 5 years. Composite assessment of a child's growth and nutritional status should be based after considering all the growth charts together and the trends observed over a period of time. The presence of any of these findings in the growth chart may indicate a problem or suggest a risk. A flat line, since it indicates that the child is not growing. A growth line that crosses a z-score line. Sharp incline or decline in the growth line.